Okay, great. Let's start. Okay, good afternoon, everybody. My name's Arpana Patel. I'm Vice Chair at NHC, and welcome to our October meeting. We've got a good agenda. I'd just like to remind everybody to keep yourselves on mute. If you've got a question, please put it in the chat bar or raise your hand. And the meeting will be recorded and will be available for circulation or use after the meeting. So, have we got Kelley here? So Kelley Webb-Martin is our Head of Children's Health, so she's going to be talking to us about the 0 to 19 service. So Kelley, over to you.
Looking to see if she's actually logged in yet.
I know, I think.
Ah, she is. Let's go. Just come in now, Arpana, so hopefully.
Oh, okay. Hi, Kelley.
Hi, good morning. Good afternoon. Sorry, I'm really apologies for. I had a few technical problems trying to join this meeting.
Oh, that's right. We're happy to see you, and we're looking forward to hearing from you. Are you ready to go?
Okay. Yes, I'm ready to go. Absolutely, I'm ready to go.
Okay, over to you then.
Okay, so thank you for having me. So just as a brief introduction, my name is Kelley Webb-Martin. I'm Head of Children's Health in London Borough of Newham. I was given the amazing challenge of being one of the first services to be transferred into London Borough of Newham, an NHS service. So I was given that mandate in 2016 to kind of 2P over or move and shift health visiting and school health into the council. At the time, there was only one place in the country that we could reference, and it was somewhere in Redcar, a place that I've never been, somewhere in the north of England somewhere. And of course, it didn't reflect our beautiful population here or our rich diversity and the way that we do things in Newham. So whilst it was great to have a reference, it really wasn't a reference for us. So to be frank with you, I did make it up as I go along. I worked with people who had that will and that ambition to really see the health and social care agenda realign. And I was I'm really proud to say that I worked with a really good collaborators to shift this service into the council. It's been 5 years since we've been here. It's been quite a journey having a clinical service in a council environment that I don't think always understands the NHS and the clinical mandate, but we're here, we have relationships with our social care colleagues. We work closely with those in areas that we would never be able to, such as housing and parks and all sorts, having access to data that we wouldn't normally have access to if we were still in traditional kind of NHS mode. And prior to the service being in the council, it was in East London Foundation Trust. So there's been some ups and downs and roundabouts, but there's lots of pros and cons. So today, I'm going to attempt to give you an update on children's health and 0 to 19 and Head Start service in the context of the council, but also to kind of, find out from you how we can work a bit better, how we can develop stronger partnerships, because I'm always in the, looking at emails where, lots of, for example, GPs may not know who the health visitors are. They've never seen the health visitor. I see all these emails and I'm thinking like, oh my goodness, why is this still happening? So it'd be really great if we can, work together so we could strengthen these partnerships. Remember, in terms of the way children's health work, our closest allies should really be primary care, because, obviously we are both universal in our approach. We see everyone, and also in terms of children and young people, I know that in terms of MDTs and things like that, it's much stronger in the adult world, and it'd be great for us to have that kind of strong, working relationship like we do for adults. So that's one of the goals I think we can have, and then also to kind of, work through some of the issues that you may have in terms of, working with staff in our service who provide services for fathers and mothers of newborns in terms of health visiting, but also, which is the area that I am most interested in, for the 5 to 19 school age population, which I feel is where we need to have more focus on. But that's just my perspective from looking at our case work and the things that we see in our borough. So if I can ask the person who's managing the slides to move to the next slide, that would be really helpful. Thank you. Okay, great, thank you. So in terms of a brief, who we are, what we do, and just as a quick update, the 0 to 5 pathway is a health visiting pathway, and I'm trying to kind of separate services from the bigger picture, because we sit within something called early help in terms of how we organized and structured in the council. Up until a couple of months ago, we used to be part of a directory called Brighter Futures, but that's been kind of disbanded, if you like, and now we're back in children and young people services. So essentially, Tim Aldridge, who's our corporate director and who's in charge, you probably would care Tim very much in terms of social care, but he's the sort of lead in children and young people service, and he manages director of early help and children's health. Her name is Audrey Johnson, and Audrey is my manager. So that's generally the structure. And we sit within that Children and Young People Service Directorate, which also includes our MASH, social care partners, intervention teams, as well as education and, looked after children and all that sort of stuff that sits within that directorate. But I'm focusing specifically today on health visiting and school health and Head Start for this particular update. So as you all know, and this is nothing new, health visiting is very much concerned about the Healthy Child program. And that's, it hasn't changed very much over the many years, but it's just been more focused. They've they've refreshed it over the years, and certainly last year there are some new milestones added to the overall template. But generally, it's looking at those key deliverables, at the key milestones of a new parent up until the child starts school. So essentially, you have the antenatal contact, which tends to be before 32 weeks of pregnancy. And in that contact, really one of the key things is making sure that, parents are being prepared for obviously this birth that's coming, working closely with the midwives, but also that the Healthy Start vitamins and the vouchers is kind of raised at that key point, because that we do have vitamin deficiency in our population. We all do, probably are all vitamin D deficient, but also the Healthy Start voucher is really sitting in that space of helping to support parents with healthy eating and access to food and milk via the universal program. So about 2 years ago, we launched the universal Healthy Start vitamins in Newham, because it's much better than having eligibility. It's much easier to respond to, and everybody's, I think, is deficient. But also it raises the profile of the Health Start voucher, which gives parents a certain amount of money if they're eligible to access, milk and vegetables. And given that we're in a cost of living crisis, I think it's even more important to raise the profile of that. Then we have the new birth visits, which is around 10 to 14 days. So on average, we've got 5,000 to 6,000 new births every year in Newham, and our target is to see those families by the time baby is 10 to 14 days. Currently, our aim is to see at least 96% of all babies born within that period of time. And of course, we would like to see everyone by 30 days of birth. Then there's a 6 to 8 week review, which is, really a key review, particularly around mother's maternal health, but also around baby's development and infant feeding and things like that. And the 12 to 15-month review, which is obviously another significant milestone in terms of baby's development and also mother's, maternal well-being, and fathers as well. We mustn't exclude the, both parents, but also thinking about, the kind of development of that child. And usually in terms of global development delay, whilst ASD and things like that are diagnosed 2 and after, you could see signs. So early intervention, early referral, and things like that. And then you have the 2.5 year review, which is also it can be an integrated review with our children's center partners. So that's the key mandates. And that's not all that the service does, but that's the key mandates that we must ensure that we do, so that we have the option of ensuring that we give the best possible care for parents and their children, specifically because we know the public health priorities that we're trying to achieve, which is around oral health, uptake of immunizations, and all the things that we're all working together to do. So I've listed those sort of NHS local authority priorities that, comes with the mandates that we deliver. Immunization, oral health, healthy eating. We're working on our BFI, which is the breastfeeding, into the UNICEF BFI standards. We've achieved stage 2, which means that we are giving good advice. Parents are feeling supported in terms of infant feeding. But now we're going to stage 3, which is a little bit harder to achieve, but we've set ourselves that target. I believe our maternity services are also on that journey. We also really want children to be ready for school. It's no surprise that some teachers, unfortunately, are finding that reception age children are not ready, in the sense that they're unable to feed themselves, or some of them, unfortunately, COVID has had some impact in terms of them being fully toilet trained and things like that. So school readiness is really quite key. Maternal, paternal mental health. Of course, a focus on children who require additional support, and that's within our specialist end. So we've got health visitors with a specialism around SEND, also perinatal mental health, as well as looking at other, issues around long-term conditions, etc. Our parenting support is embedded in everything that we do, but there are specific programs that are available in the wider local authority offer, working with our children's centres, as well as our early provision in terms of nurseries, etc. And of course, everybody's business, safeguarding and child protection. So that's just kind of summary of some of the things that we focused in terms of the Healthy Child program and what we deliver. Other things that support how we work is around the infrastructure that we've got in the service. We've got a duty desk, a single point of access. So I want to really highlight this, because even if you don't know your health visitor, you've never seen a health visitor in your life, or you have trouble getting in contact with her, etc. There's some contact details at the end. We have a single point of access where we have targets against answering that phone. Right now we're kind of like 97% on the first 4 rings, and I can tell you that with some confidence, because we have some analytics on the switchboard, so we know for sure. There is always someone that you can call to find out information, so that's available, and I'll share those contacts at the end of the slide deck. And of course, through our single point of access, we also have a process of looking at client feedback, the good, the bad, and the ugly, what we're not doing so well in, and what we need to improve, and also things that we could pat ourselves on the back when we get good satisfaction results. And of course, our single point of access is the heartbeat of the entire children's health service, because it's where our workflow comes in. So we get thousands and thousands of workflow data every day, and that's information via the hospital in terms of discharges, children who attend A&E and maybe had inpatients, etc., and they've been discharged. We get information, flowing from our hub, which is based in Raynham, which is all the stuff to do with babies being born, blood spot testing results, you name it, we get it. Thousands of data coming through. And of course, we have access via our clinical recording system to the NHS Spine, and we can have a sneaky peek at your email system as well via there, as well as other systems connected to the council. So it's really getting a lot better in terms of information sharing with regards to our ELPR, which is our HIE system, which I'm sure you have access to as well. In terms of research in health visiting, we've been very proud of our investment in research. And I say this because we're in a council environment where we don't have the clinical kind of assets that most NHS organizations will have. So to do additional stuff takes a little bit more effort. So that's why we're so proud that we are still able to do that. Some of the things that we've done in the kind of 0 to 5 space is around ACT early research, which was looking at the COVID impact. So we recruited quite a large number of families to look at the impact for children under 5s, and that was done in collaboration with UCL. We're currently doing NEON, which is the infant feeding research, working with UCL again, and this is around South Asian families. It's a very good project, and we're very excited to be supporting that. We did our speech and language research with Newcastle University quite recently, and we were able to really have impact in terms of a toolkit that's now being rolled out nationally as a result. And we now have something called Talk in Touch, which is a program specifically for children who may have some delay with regards to their speech and language, which the health visitors are providing. And we currently have something called Surviving Crying with De Montfort University, which focuses obviously on, the response to crying babies and, the whole safeguarding thing. And that's very early. We're still recruiting for that. So those are the current things. And Sule would know that we, at 2 seconds before submission or 2 seconds after submission, we've recently submitted a bid in collaboration with UEL, and that Sule is co-applicant and supporting as well around an NIHR bid, which is around engagement, looking at co-production and how we engage to get health outcomes and getting people to kind of health equity stuff and all that kind of lovely stuff. So we're waiting to hear if we're successful with that. And of course, I will put a couple of links in the chat afterwards, because there's one particular video I'd like you to see. We've got a really great social marketing strategy, which was informed by the young people that we have work placement experience with, who said that they don't read any of our leaflets and they don't look at any of the things that we send via paper, and therefore stop it. And that was about 3-4 years ago. So we kind of changed how we look at how we target stuff at that kind of school-aged cohort. And we're really trying to get on more savvy with our digital and social media offer, but certainly we've been very successful with our social marketing in terms of filmmaking. We've got about 24 films or so made with children and young people in the borough, co-produced, scripted, acted, filmed with parents that you may see in your practice. And I'm sure if you look at some of the videos, you'd probably recognize some of your practice residents in there, et cetera, et cetera. So that's been very successful. It's been 2.5 years. So we're going to evaluate the impact of our social marketing offer. Next slide, please. Thank you. So moving swiftly along, as you know, at Rising 5 is when the health visitor will stop and hand over to the school health team. And usually this is around 4 when a child is 4, because they're either entering primary school. And at that point, our school health team, which is a very small team, and I need to say that because a lot of people would want to get in touch with our school nurses and may struggle. We have a teeny tiny school health team. And in fact, I think there's less than 2,500 school nurses in the country. It's a very, very small workforce. So it's a real effort to recruit into the school health team. And whilst we're aiming, although this doesn't measure what we need, we're aiming to have at least 22 school nurses in our team, and we just about have 12. That's being, very, very honest with you. So it's a real precious team, but they work really, really hard, and we've got lots of skill mix within the team to kind of meet the demand of schools. We have almost 66,000 children in schools. So if you think about that in context of 12 to 15 to 18 to 22 nurses, you can tell what the demands are. Each nurse will probably carry around 6 schools, and it's intense in terms of managing, particularly where there are additional needs. As you know, we are a very inclusive borough, so we have children with significant needs within kind of mainstream schools, and also mental health is quite significant now, as we all know. But if I talk about the Healthy Child Program in context of the school health, there's lots of things that they get involved with. But one of the key things that I suppose interfaces with all of us is the National Child Measuring Program, or NCMP, which really is BMI. So BMI at 4, that is reception age. So we, on average, we would have the weight and height of every reception age child, roughly 11,000 children every year. And that happens around 5,000 or so in the reception age, and then around 5,000 or so in year 6. So we've got entering primary school and leaving primary school, if you like, in terms of their BMI. For about 12 years prior to the service being transferred into Newham, children didn't have vision and hearing screening. But you know, it's one of the things I was really desperate to restart as soon as we were able to, because there are some children who may display behavior problems or maybe even lots of issues, and actually it's because they're probably not seeing or hearing very well. So we've implemented vision and hearing in the service has been in the council for 5 years. I would say maybe 3.5 years, something like that. Vision and hearing. So we've got a screening program for that. And, you know, one of the outcomes I can say is that we actually was able to identify someone who was profoundly deaf since we commenced it. So I'm really pleased that we've got this program going in. On average, again, about 5,000 children hearing and screening, because we only do it in reception at this point. We are hoping to implement in the adolescent period, targeting specifically the PRU, because we know, like I've said, sometimes children's behavior is because they're not, in terms of their vision and hearing, isn't that great. So we've asked for additional training so that we can do vision and hearing for that age group. Because of capacity, we haven't been able to start in the time that we wanted to, but it's still very much in our plan, and we hope that we can commence that quite soon. We also do school entry health assessment, and predominantly this is very, very parent and school focused. And essentially it's a link that because we've automated it, because obviously we're trying to think in terms of lean ways of doing things, given capacity. So we automate this, and it's a link that we send to all parents. And we're very, like I say, one of the benefits of being in the council is that we have access to pupil entry data now, so we can piggyback on, you know, that kind of school entry application, and we send this link to all parents so we can start to build a picture of the child as well as the school. And this school entry health assessment, sometimes called CHA, really says, who's this child? What are the long-term conditions? Are there any medical issues? Are there any other social issues? You know, and parents, you know, start filling this in, but also the school is listed there. So we can say, okay, based on looking at a school, let's say school B or school A, there's, you know, 100 children with asthma. There's 600 children with, you know, whatever. We can start to build that profile of the school via the school entry health assessment. Our main thing was to kind of get to the point where all parents fill this out. Obviously, that's always been the challenge. But what we've tried to do is to ride on the 100% application rate that our people services get, because everybody wants a school place for their child. And we've seen that the school entry health assessment increase over time by sending it out whilst we send out the application forms for schools. So that's been helpful in building that picture. As you can see, those are the kind of NHS and LA priorities that school health are focused on, which is really around the long-term condition care planning, emotional health and well-being, special support. We've got now young carers support. We've got the youth safety provision in terms of school nurses, specialist responsibility, healthy eating. And we've got a program called LYBL, which is Live Your Best Life. And really it's a transition to adulthood program. So it's a group kind of workshop style delivery with partners, sexual health, you know, preparing for leaving school, that sort of stuff, that's delivered in a clustered approach. We would like for it to be delivered in a school cluster way, but it's been very challenging. So what we've done is to focus it in a kind of youth zone kind of basis. So we kind of deliver via the youth zones and ask young people to turn up. And of course, there's a school health duty desk. There's always a school nurse on the duty desk so that people can call in, do referrals, things like that. And of course, safeguarding. One of the things that we've been very proud of is our whole school asthma approach. In the last last year, we commenced something called whole school. We've understood by our analysis and by the facts is that the highest long-term condition within schools is asthma. Is one of the the areas of great concern, and having individual care plans isn't necessarily the thing to do, but to have a whole system approach to managing asthma, i.e. everybody in the school knows what to do. So it's a bit like if you think of your fire safety signs that everybody knows, this is what you do, this is what you, so that sort of approach. And so we provide training. We've provided training for over 1,500 school staff since starting the program. Or maybe it's about 2,000, I can't remember, anyway, whatever it is. And also we've managed to get over 90 schools to kind of join up on this, which meant that we've got a framework for having a whole school asthma approach within these schools. Because it's done so well and we've managed to share our learning from doing it, we were nominated for the LGC award quite recently. So I had a little bit of champagne not so long ago in the event. And of course, we didn't quite win, but we certainly got the commendation, which is the second award for our project, which is really great considering the size of the team. I want to go back, 12 nurses, a couple of agency, that sort of stuff to actually achieve that nationally. I felt really proud that, our staff was able to do that. And right now we're hoping to, thank you, we're hoping to move this into leisure centers now, so that it's, not just within schools. And there's some plans around that. It would be great if we could do that for all of the long-term conditions. I mean, we do provide epilepsy, allergy training for all the schools. So whilst we're doing the asthma, we do epilepsy and allergy management and things like that. But obviously, we have to really think about our resource and how we can maximize on that. So focusing on the long-term condition with the most amount of requirement is the one that we did. Child health is mental, well, it sits within emotional health and well-being as well as physical health. Essentially, it's a texting service where children and young people can text the service and ask whatever they like. So, I feel bullied today or anything. I've got a headache, whatever. They can text in and there's someone who will give a response directly. It could lead to a conversation, it could lead to a face-to-face, or it could just be anonymous, completely anonymous, because it's anonymous. It could be a signposting thing. So stuff that maybe children and young people don't want to say out loud, but they can say it anonymously, that comes through to the school health services. A little bit like COOF. I'm sure you know COOF is targeted very much at children and young people in terms of mental health, and it's online, but it's anonymous, so that there's a lot of engagement. It's a bit like that. And of course, I mentioned the social marketing stuff. We do have films that are focused for the adolescent age, made by the young people, etc. So that's the 5 to 19. And then finally, because I don't want to be death by PowerPoint, and I'm aware that I have a few more minutes and I'll take any questions after. On the final slide, I just have a little focus on our emotional health and well-being offer, which is our Head Start program. And I should have said soon to be changed to something else. So our Head Start program is, and I'm sure lots of you know about the Head Start program. We've been very lucky to be, I think we're the only borough in London to have had that £6 million investment over the last 6 years to roll out emotional health and well-being for our young people. And it was very much for 10 to 16, so that school-aged area that maybe has the most amount of need. So Head Start has been in the borough for that time. We've extended it because of COVID, so it ends in March 2023. That's because the funding ends then. And what it is about providing just resilience and a whole range of tools and interventions to support emotional health and well-being. There's a youth panel. The youth panel is into social action. They're very, very confident young children and young people who come together to take charge and discuss what they want changed, etc., but also to co-produce some of the interventions that is on offer. Your Time First and Your Time is probably our most unplanned but seems to be effective intervention. When Head Start started, there was a number of things that were there that no longer exist because it's a test and learn research styled program. Your Time started in COVID and it sustained itself because of its need. And essentially it's a 12 to 18 week telephone program where children and young people call up and get support, counseling, stroke, emotional well-being support at tier 1 level, if you like. So the idea is to get in before CAMS is required. And the measures for this is using an outcome star approach that we can see how effective it is. Your Time First started because whilst Head Start is very much about 10 to 16, we found that some children were calling that were below 10. And as a result of that, we started Your Time First, where school health really focused on that for the under 10s. Bounce Back is another resource. It's also online, again, available for children and young people. And it's all well within everyone's gift to share that so people can kind of do some self support for children and young people around resilience, a whole range of things to do with mental health and well-being. We also have, as part of this year, with Head Start Wellbeing Roadshows, which is delivered in sort of school environments or community spaces, and a whole range of things are done within those roadshows, depending on what teachers predominantly feel are emerging problems within the school population or what children and young people may suggest themselves. There's also peer parenting support. We've got something, local parents were trained to be peer parents, and that's available, and that's going strong. It's completely commissioned now, so that's not going to, although Head Start is coming to an end, that's been sort of mainstreamed, and we've got local parents that are delivering peer support to parents to support their children. The Newham MAC is probably one of the things that also come out of COVID, driven by COVID, was weekly cross-sector partnerships. So basically, we've got at least 20 VCS organizations that will come together along with a rep from CAMS, Head Start, School Health, Social Care, whoever, around the table around particular cases. So we have early intervention, and that we could order therapeutic support by the best person. It could be that West Ham United might be the best place to support this child. Maybe that's what's required. It could be Community Links might have a particular offer that might support this child's or young person's well-being, and that might be the best place. It's not always about the traditional health model, as you know. There's some community stuff that actually would work better, and that's the whole point of the Newham MAC in terms of well-being support. And of course, I mentioned the peer parenting already, so that's kind of a repeat of that. So that's essentially it. And then the final slide is that happy tag page that I mentioned, and please feel free to use that on the last slide. If we can move that, actually I forgot about. Sorry, if you go back before, I forgot about the 3 things that I wanted to talk about: stronger partnerships with primary care, which is really looking at what we can do, what would make the outcomes better, how we can work a bit better. And one of the things is I want to work with Newham Training Hub, which I'm pleased has progressed in such a way in the last 2 years that we've managed to do a lot of learning together across, the system. And now we're obviously learning from a very successful project called Youngest in Charge, where we were able to give young people a budget to get on with producing projects, £500 to £5,000 to kind of develop projects. We had 8 project leads and all of them were steeped in mental health, and it's been very successful. They were able to reach over 300 children and young people themselves and provide sessions that maybe our school health team or yourselves wouldn't have been able to do as professionals, but they were able to reach that population and have some really good outcomes. And also we were in that regard, we are looking at the evaluation now, and it will be published, so we can see how we could build on some of those some of the outcomes that we had from that program. And then the system induction, currently we're working with East London Foundation Trust. Sule would know about this. We hope that we could work with you in developing a system induction, which says this is Newham, so it doesn't matter where you sit in Newham, whether you sit in the VCS, whether you're a police officer, a nurse, a doctor, whatever, you can have this induction. And we're hoping to do a short film and other things, a treasure hunt, all things. So I'm sure we'd be looking to you to be in part of that film. I hope some people are not camera shy and they'll be happy to kind of nominate themselves to be part of that film. And it's coming on board quite soon. We'll be sharing that briefing hopefully before the end of this month. MDT is something that I think, we, like I mentioned earlier, we could probably do a bit better in terms of looking at children. And I know that I think Helen is on here and others who are part of the improvement QI, NEL stuff about improving communication and case management around children's issues, focusing on things that are really wicked problems for all of us. And I guess that's something that there will be some investment in with that. So I look forward to us, having better MDTs. But in the meantime, we do have health visitors aligned to practices, aligned to children's centres, and sometimes it's not always well known or communicated. So I think we need to do some improvement around that. And there's one staff who's been given that lead responsibility to make sure that you have that kind of information to facilitate those conversations with your health visitor. It's a little bit trickier with school nurses because they work across schools, and of course there's several GPs involved. Some children don't even live in Newham, etc. But it would be a real achievement if we can find a way for school health to have that same dialogue with primary care, because in my experience, that's where we need it the most. And of course, improving access for school-age children in terms of long-term condition management. There's lots of things that we can do together, particularly for maybe practices that have additional resources, such as new GP fellows and the new trainees and things like that, that might be able to co-deliver with school health or have interesting projects and programs or QI work. And then finally, the contact page, which is there. So if you want to know about, if you want to contact a school nurse, just you can email, or you can use a duty desk, Head Start and Health Visiting. The website's there, numbers are there. I'm here. You can contact me anytime. My email, I'm happy to share as well at the end of this. So, let's work together to do what we can, and let's see how we can improve our communication so that we have the information that you want us to have, and you have the information that we want you to have. So thank you very much, and I'll take questions. I know there's questions in the chat, so I'm gonna try and pick some of those up.
Thanks so much, Kelley. That's I think you've highlighted for many of us that there's lots of work being done that maybe GPs and practices are not aware of. I had a few queries for you, or a few things that I think you could help clarify. So you mentioned that there's a sort of a contact to ensure that there's a health visitor aligned to each practice. I think many practices are not aware of who the named health visitor is.
Yeah.
A lot of patients are given the single point of access contact number, and they're coming back to us saying that, oh, when I phoned that number, I was told that our surgery doesn't have a health visitor. So they said to go back to the GP. And I've had a few patients mention that recently.
Right,
so I think that I've spoken to Barbara, and she mentioned that the health visitor that I had in my practice, for example, the first one left. Whoever covered her after that has left. So what would be useful for practices is to have an aligned health visitor, but also have somebody that we can go to if we don't know who that is, so that information is being kept up to date for each individual practice. And I think following on from that, the MDT, where are we with MDTs? Are we looking to do this on a practice level? Because I know that this is something that a lot of practices would be really keen for, in improving, just the care in general that's provided for all of the children.
Yeah, I mean, what's good in terms of, okay, so if I answer the thing about the contact with people calling the SPOA, one, I'm grateful they got through because of the target, but I'm sorry to hear that they were told that they didn't have a health visitor, which is something we're going to have to work on. And there's absolutely factual that we do have vacancies. Our optimum level of health visitors in the borough should be 99 to 100. In terms of what's permanent at the moment is 68. In terms of what we can do in terms of agency, we've got about 12 to 15. So yes, we do have a gap, but that is not your problem. That is our problem, and it's not the user's problem either. It's still our problem. We have skill mix. There's somebody in the team that the individual should have been given to resolve their issues. So that's something I'll take away to work on. In terms of the MDTs, Helen, I know that you're here. We're at the very early stages of planning what that could look like. There's two models that it's being explored. I think we're looking at best practice. People are going out to see how they're doing it in other areas. We've had a couple of webinars to see what's been successful in other parts of the country. And I guess there's some license in us creating our own. Now, I think the cluster would work. Helen, if you're here, I don't know if you want to come in to describe what's.
No, I think you've done it perfectly, Kelley. It's early days. They're looking at working with the Institute of Health Improvement, various models, and then looking at the various other ones that are going on in Newham at the moment, including the frailty MDTs. And I've also encouraged the CCG colleagues to look at rationalising the approach across all the PCNs, because we can't load extra and extra and extra in a PCN environment. But I think it's looking really good. And obviously we're going to, they will come out and do some focus groups with the GPs. I was on a call with the lead yesterday, so we can design it. It will be designed around the requirements of the practices.
Yeah, thank you, Helen.
I think, Kelley, there's one mention of Wax has mentioned that the aim is to have one school nurse per school. So obviously,
Is the aim? Is the aim? Don't fall off
that
your
is the
chair.
problem, and it's just not in Newham; it's nationally.
Right.
But he's mentioned about healthy lifestyle and asthma being a bit, being more proactive within the schools. But what about immunisation?
Yeah. Absolutely. So in terms of having a school nurse per cluster or per school, that would be my dream too. But the national picture is what it is. We're looking at skill mix. So we have screeners. We've developed some competencies around screeners. So we've employed screeners, and they focus very much on vision and hearing and CMP. And we're looking at skill mix, and that's why I'm saying, is there opportunity for us to collaborate with the new GP trainees and things like that, so we can increase our capacity to do all the lovely stuff that we want to do. Now, in terms of immunization, absolutely. As you may know, before NHS England commissioned it directly, the school health team were responsible for giving immunizations. And guess what? Immunizations for school-age children were higher then, but that was taken away and given to a national. And so, as you know, locally, we've got Vaccination UK that actually delivers the school age immunization. So it's not us actually doing the doing, although we provide as much as the immunization awareness stuff, helping with Vaccination UK, send them lists of children, all that sort of infrastructure support. But the thing that really matters is the jab or the drops or whatever we're given in terms of immunizations, but we don't actually have that commission within our service anymore for many years. So unfortunately, our scope is reduced in terms of that. But raising awareness and doing projects such as the Youngest in Charge project, Living Your Best Life, all of these things are ways that we make every contact count in terms of getting immunizations kind of raised for children and young people to make their own choices, but also for parents to consent for the younger age group.
So
I think that was the other question.
Hands up. So first of all, Laura quickly, and then Wax, and then I think if we've got any other questions, Kelley, we can either collate the questions if people want to put them into the chat bar and share them with you, or people can contact you directly if that's all right. Of
course, yes, thank you.
So Laura.
Hi, Kelley. Thanks so much for a great presentation. I wanted to say we've got a really excellent health visitor linked to our practice at Tollgate, and she's been with us for years, and it works really, really well. What I have noticed though at our meetings is that very often we're all scrabbling for information and updates from the social services.
Right.
And I've been trying to press for this, and I've involved Emma, head of safeguarding, GP head of safeguarding, about seeing what we can do to try and get social services along to these meetings as well, because most of the time there's information that we don't know about that Yinka might know about, and vice versa. And often it's very much about, well, what's happening with here? And the end point's more about talking about the children need to chase with social worker because none of us know what's going on.
Yeah.
And then it's a case of, right, we'll send a letter, but then we don't get anything back the following month. And then it just feels like big waste of meetings. And I just didn't know whether there was anything that could be pushed from your side about that. Well, about, I don't know. Well, again, it'll be an availability thing, and I get that. But at the same time, even if it was to every other meeting that we had someone who was able to do that, because it seems such a waste of otherwise it could be a really productive meeting that we have, because we've got really excellent staff from the health visiting side, but we're all scrabbling around and it seems really inefficient and it's not fair.
Okay, thank you. So I'm guessing this is about case by case and having the social care picture along with the health picture on a case by case level. Is that what you mean? Or are you thinking about social care systems?
So yeah, what we do is when we obviously have the health visitor appointments, we make sure that we bring everyone who's on you know, a looked after child or on a plan. We bring those to the meeting and we want to talk through them, because obviously they're the most vulnerable children. There are others as well, obviously, but they're the most vulnerable children, and we're just missing things all the time because of it, because we don't have that key information from the social services there. I know that's obviously not your responsibility, but it would be great if we could push from all sides for that.
Yeah, sure. I think that's and can I just ask one question? Are you able to read across to ASIAS from via EMIS?
Are we able to what, sorry?
Read across to ASIAS. So social care, they use a system called ASIAS, so some people say ASUS.
Yes, so we can see stuff in the portal when it's there. Very often there isn't stuff there, but for example, Yinka might say to us, oh yes, this patient is on a plan, and then we go into portal and we can't see anything.
Right, okay. Okay, right. So I see. Okay, so yeah, I mean, I think it's a good point if that's the case. So if the information, the whole point of us reading across systems is that we can quickly have a look. But if it's not there, then that obviously that's an issue. And then in terms of bringing information, if how we can ensure that social care, I think there's my equivalent is someone called Maf, and he's more or less leading on the MASH. And I will have a word with him to see how we can bridge that gap. Either by having that information provided ahead of someone like Yinka's time with you, so that she can, you know, maybe provide some information. And that would work also not just for those cases that are on tier 3, which is the CIN and the CP cases, but also the early help cases, which are often the ones that are probably more worrying because nobody kind of hovering in between the universal.
And just another thing to point out as well, at those meetings, we've obviously got people on our plan, and there's obviously a specialist perinatal mental health visiting team who don't come to the meetings, and Yinka doesn't have that information. So again, we're missing information from those very vulnerable families.
Can I just suggest that, Laura, you know, you're giving lots of really good, and I think it's really useful feedback to Kelley. Perhaps if it's all right, you could take this conversation and have it outside of the meeting, because I think, Laura, you're actually giving a lot of constructive feedback that Kelley, I think you would find useful.
Yeah, thank you. Yeah, I would value that. I'd value that in terms of, because if we can, you know, kind of, you know, close those gaps very quickly, I'd really like to hear about them. Thank you so much for raising those things. Yeah, thank you.
And Kelley, thank you so much. I think there's been a few comments as well that your update has been really useful to practices. So thanks for sharing the contact details as well for everything here. And I think we have your direct contact as well. If we need to contact you, is that all right to share that with
Yes,
Kelley?
of course. I'm going to go off camera, obviously, because I'm finished this. I'm going to put a couple of links in there. One, my email address. I'm going to put that in the link. But also, I'm going to maybe put in our social marketing playlist and one particular video that I would suggest that you all look at individually because it's so special. And on that note, I'd like to say thank you for having me here, and for Maggie and others who've arranged for me to get onto the agenda.
Great. Thank you so much, Kelley.
Thank you. Take care.
Thanks. So Laura, have we got Laura? Sorry, Laura, we're running a bit behind.
That's fine. No, I appreciate it. Do you want me to try and make mine much shorter?
If you could, please.
That'd be helpful.
We need time for questions. We've got
no, absolutely. That's fine, because I appreciate it. And Kelley's presentation was great, so I can see why she needed the time too. So that's absolutely fine. So I'm kind of, I was offered a slot quite just this week, which was really great, but because it gave me an opportunity to come here when there've been quite a lot of issues raised recently around housing, which isn't obviously a new thing for Newham, because of housing and health being such interrelational partners. So I'm a public health assistant director of Newham. One of my portfolio lead areas is housing, and I was just going to update on 3 things. One, around just giving a bit of information about the energy support that we are putting out there for residents around warm homes this winter. That's part of our cost of living response. The second was around thinking about, we're trying to bring together information which can help you with wider range of housing issues, that not expecting yourselves to be able to necessarily handhold patients through, but to be able to at least signpost to the right email address, the right place. Particularly, I think the social prescribing team raised this. And then I was just going to very briefly sort of share why, like a lot of systems at the moment, housing is sort of feeling particular strain. And to help maybe manage some of the frustrations that residents might be experiencing. So, I mean, are those, do you want me to go through slides or just give a verbal update because everyone can see the slides? I mean, I'm not going to talk through this because you'll probably know it, but this is the data around where we know the highest levels of fuel poverty are in Newham. We can see it's mainly around that northeast of the borough, but because of the energy crisis, this is on 2020 data. So we are very much thinking that we need to scale up information and support across the borough. So if we just go to the next slide. The current, these are in terms of thinking about particular at-risk groups. These are where we know that the current the current energy support package by the government will not necessarily reach. So we know that private renters have particular affordability issues. So around 60% of income is spent on rent in Newham, and we've got the highest proportion of people renting privately in any London borough. And we know that private rental properties tend to be more energy inefficient. That next level, we also have 13% of sort of properties in that lowest rating, band E, below. And we are working with landlords as well to try and improve this property. We know people on prepayment meters have higher bills regardless of the energy cap. And we know obviously that for people who require higher energy usage to keep well, so the older population, people with chronic health conditions and people with disabilities can be higher energy users, and then larger families and households. So the estimated annual bill is being put at around 2,500, but if you're a larger family, it's been estimated to be around 3,450, and that's a lot for many Newham families. So we're absolutely aware of how big this issue is. If we go to the next slide, what we're doing. So this on the right hand side is a leaflet we've developed, which we will be printing in the next week in paper copies, so we can distribute to surgeries, to receptionists. We can think about screenshots for digital displays. But my main messaging here is that there is free support. Some of it is around sort of like insulating homes, but I've looked at the data. One of it is a line called Shine. We promoted this lots last year in our winter wellbeing, and I looked at the uptake of it last year, and it was very low. With the lowest numbers for private renters. So we're aware that we need to really encourage the fact that this is free support, and you can get, if you're on a lower income, you can get free installation. And we really want to make sure that Newham's residents get what they're entitled to, and that's one of our key parts of our cost of living crisis response. So this is all part of what we're doing around our winter wellbeing and our cost of living crisis response, with thinking about direct support, but also ensuring people take up the entitlements and resources available to them. So we're looking at how we can make these leaflets available, tenants forums. We've got information in some of the vaccination home visits, the warm havens that we're setting up across the borough that will be available from November. We'll have this information there, and we're trying to get some funding to help some more like community advisors to be in those roles, so it's more people facing. But it's just to make you aware that we can make this kind of information more freely available for you to be able to share out. And we're also developing an information leaflet on the risk of damp and mold, which also causes some really challenging health concerns around respiratory health, and it's unlikely people will want to ventilate their homes when they're feeling cold. So we're trying to give that best advice about things like put your washing in your bathroom with a slight window open rather than having it in any area that you're sleeping in, and just working with our environmental health colleagues on some good tips. Then the next slide. So I'm racing through because I'm ready to be quick. Now this has come up, and this is something I think we have a public health outreach team, and initially they came to me, and then I think Helen, you've also been speaking to Izzy about this from the social prescribing, that it's really hard to find out information about where to go for housing support in the borough. So we're putting together a frequently asked questions, including like where to go for pest control. If you have that, unfortunately, it's different for damp and mold if you're in a council-owned property or a private rental property, but we're giving information about both of those. And I see this as more making sure that people who are in the social prescribing roles or community connectors, that they have this information to hand, but it might be something you think would be useful to have as a central resource as well. So eviction concerns and antisocial behaviour. So this is at the back, and then the last slide flags up that there is now a housing hub in Stratford. It's only though you can only just turn up if you're in a council-owned property. If you're in a private rental, which we know affects most of our residents, you need to do a pre-arranged appointment, so you need to book an appointment. But they provide a hub now for anyone around a whole host of issues. You probably don't just get one housing issue, you probably get about 3 or 4 altogether. So again, we're trying to make clear information around that. So that was my energy information, wider housing information. You will know that there should be more housing hubs next year. The housing teams themselves, they're seeing more and more people presenting to the Homelessness Prevention Advice Service. So really concerned about with evictions. And they're having more problems recruiting staff too. Really, really difficult problems trying to recruit more housing officers to the team. So I guess it's just me sharing from my interface with housing colleagues that they are also under quite a lot of strain, and I know that must be really hard for residents. It must be really hard for yourselves when you see people really struggling in their home environment. And we're trying to provide the best information that we can to help provide some of those pathways and support. So that was all I was going to say, really. And if you think, I mean, unfortunately, I can't build homes, but from anything else from a public health perspective that we can help yourselves with in terms of your interactions with residents, do let me know.
Thanks, Laura. And I think, Rima has pointed out that, the important thing here is to communicate all of this information to our residents. But I think that, I wasn't aware of many of these things that are available. So I think this has been useful just for us as well. What are the forums that this is being shared with to residents? What forums is this information being shared in?
So in terms of some of the forums, so they have the housing teams have recently set up tenants forums, and these things are a little bit by, what tenancy you have. So whether you're in social housing or private rental sector, and every tenant gets like a tenant pack, but it is quite hard. I mean, I've gone through it myself, and that's why we pulled this information out. It hasn't been through the housing team. It's just because we keep hearing from our colleagues. So our public health outreach team, they go through across the borough every week, and this is a common issue coming up. So that's one of our routes we're relaying to residents. We're going to put it into the Healthier Lives booklet. I have to remember what it's called. The 5 ways to well-being. So the one that was circulated to all residents last year is being updated, and we're going to be sending out printed copies. So we're including housing this year, which we didn't last year. And yeah, so we'll just do our best as we can, really, in terms of any kind of public health communication channels.
Okay, and then Wax has got his hand up.
Thanks. Yeah, so this needs to get out to those that needs it. I was just thinking, making every contact count, and whether you have any links into some of the information that we need to get out to residents around cost of living as well. So you mentioned the 5 ways kind of situation for later on this year. I mean, things like, are you eligible for a prepayment prescription, etc., and stuff like that, free medications, all that kind of stuff. All of that stuff's irrelevant because we're starting to see more and more patients that are coming in who are not able to pay for their prescriptions. There's definitely stuff that we can do, but often patients don't know, or pharmacists don't communicate that you can get a prepayment prescription, which means that it's cheaper for you if you pay for your prescriptions to go that way around rather than pay for 2 scripts every month, etc., etc., etc. So if there is an opportunity or space in that 5 ways book to get some of the most poignant points from a health perspective in there for winter and cost of living, I think that would be great if there was some connection there.
Yeah, no, that's a really good point. I'll see if we're going to include that, and I think it's still in the draft phase that we can add. Those are really good points, and this is just, there's a whole realm, as you can imagine, of cost of living information, which we are integrating it across the council in a central, like in the comms plan. We're trying not to overwhelm people. So there's information about the food banks, about warm havens, which I've just seen that note about the worry about people sitting in GP surgeries. So all libraries from the beginning of November till the end of March, every day will be providing a warm haven. And I have to say, because I know that I'm sure you all appreciate this. This is council hasn't got any additional resource here. So oh yes, so thank you, Kavita. Yeah, so has all been shared. I'm sure it has been, and there'll be other updates as we go along into the winter. But it's just to say, I think once the warm havens are open, we can share that information. So at least it provides somewhere where you can say people can go to. I'm just checking my notes. 9 till 8, Monday to Saturday, and Sunday 12 till 4.
Brilliant. Laura, the other thing I was thinking was some of our screens in patient waiting areas would benefit from this information being added on a slide, and maybe something really small that we can actually hand out to patients. That will come from social prescribers mostly, but yeah, it's good for that. And Kavita's mentioned that in the chat bar as well. Look, Laura, honestly, we're not expecting you to build loads of houses and have a blank check kind of situation. We know where we are. We know this is as a result, just like the last conversation, years and years of blooming cuts, etc., to various kind of situations. And I think this is efforts in the right direction to help as many people as we can. So well done to you and your team. Mustn't be disheartened. A lot of this is not our fault, but certainly we're in positions that we can do to help people along some of this difficult situation that we're facing.
Thank you. That's really kind to hear. I think we're just really aware of how hard you're all working to, that we're all a part of a system under considerable strain. So things that we can do to try and make things easier, we will. And yeah, just you've got, I think we've all got, someone's got my email address. Sorry, I haven't put it on the slides, but I know that Maggie does. So anything further, just let me know. In terms of the screens, who do I contact around GP screens? Because we've got such a range of infographics. We've got one that's just a one-pager, which just very clearly has all the information.
Karen, that would probably be if we.
Laura, if you lean, sorry, Wax. If Laura, if you liaise with Maggie on that, we'll try and connect with all the GP practices to get those messages out, so you can put them on screens and things, or out to practices if they're leaflets.
Brilliant, thank you.
Just one more quick question, Laura. Kavita's asked how often the citizen assemblies and the local neighbourhood meetings are held.
I don't know, but I'll come back.
Okay, great. Thank you. I think you've covered all of the other questions and queries. So thanks a lot, Laura.
Thank you.
Okay, so the next item on the agenda is an update from Leilla and Sule with regards to the PLT session.
Hi everybody. I hope that Zane is going to cooperate and not shout too loudly, but apologies in advance if she gets overexcited. I just wanted to say thank you to everybody who was involved in setting up the PLT last week and those of you who came. Unfortunately, I had COVID, so I was unable to attend, but I have had a look at the feedback that was collected. So I just thought it would be helpful just to set out where we think we are in terms of PLT going forward and the context of PLT. And then after that, I'm hoping that Sule can just share with you some of the plans for moving forward. So the NHS North East London has commissioned out of hours cover from NHC to enable practices to attend protected learning time sessions. It's the intention that these sessions are borough-based learning sessions where the agendas are agreed by the Newham Primary Care Transformation Group. So there is going to be a working group established, but that's going to be the group where the agendas will be signed off. It's intended that the learning is for all members of general practice staff, but this is aspirational. We do at least want to start off with some clinical sessions and some admin sessions, but it's quite a feat to try and arrange sessions where the content will be relevant to all members of staff. So the idea is that we start with something and then that these are built up as we move along. I recognise that there have been requests for practices to have their own individual learning time. And so what we have said is that there is a form which we can share afterwards, and practices and PCMs can put in some applications to have some half-day closure to support their own learning. But the PLT sessions weren't supposed to be individual practice sessions. They were supposed to be topics that would be relevant to the whole of the borough and would benefit from a group of clinicians or admin staff having that space for learning. So the form we can share after this. So there have been a couple of PCMs that have applied to have a PCM learning session, and everyone is available to apply to have those sessions. What I do need to say is that there is a limited amount of resource for this. So the more individual sessions we need to provide cover for, the less sessions that we'll be able to provide. At the moment, we have devised it so that we've got sessions every month. The sessions will be a mixture of virtual and face-to-face. The more individual sessions that we need to provide, the fewer group sessions there'll be. So I hope that gives the context of what we're trying to achieve with these sessions. And I'll hand over to Sule to go through the slides. Laura, you've got a question?
Yeah, sorry, can I just clarify that last bit about, because I totally understand that very often it's really useful to have whole borough-wide learning, and it can be really useful for lots of different reasons. But if for whatever reason it's on a session that isn't particularly useful, or if a practice does want to do some more in-house stuff and sort of plans that so that it does involve all members of the team, it sounds like what you're saying is if everyone does that, we can't do it and we're just going to have less PLT sessions. But how is that equitable and how is that fair? Because we're supposed to be having, we're supposed to be getting up to parity to what's going on in other areas. So it's basically a case of you can't all do it. We can't support that. So I don't fully understand that part.
So there is going to be a review happening across now, because I know that there is variation on what some of the other boroughs are offering. So the intention is hopefully by January we'll be actually turning around and saying that this is the null process. For the time being, we need to go along with what we have commissioned. So let's say, I don't know, for November session, we'll have a topic. We've got the ability to provide cover for practices to attend that session. Now, we recognise that not all practices will necessarily need to close to attend the PLTs. The PLTs are not mandatory, they're voluntary sessions. We hope that practices will attend, providing that they're relevant. But we're not saying that every single practice needs to close for every single session. It would be for practices by practice to review whether they can operate, who it is that needs to attend. And so that's why we have got some scope within the budget to cover some additional sessions. But if we have, 20 practices requiring half-day closures every month, then it is going to eat into the resource that we've got. So what we're suggesting is that those practices that are saying that they do want individual practice sessions, they need to have a half day, they need some protected time for themselves, fill in the form, we'll review it at the transformation group, and then we'll take it from there. I hope that answers the question, Laura.
I mean, it does, but it just goes to show that the funding isn't there and it isn't where we want it to be yet. But thank you. I understand you're going with what the deal is at the moment, but thank you.
Wax, did you have a question?
Yeah, so more a couple of points, Leila. I was just thinking, so I haven't really kind of been involved in this, but I guess I'll be stepping into being a bit more involved going forward with everyone. I mean, we'll have a working group kind of situation. I think that's niche enough to get the agenda right. I don't think that's complicated kind of situation, but Laura's point is well made, and you know, we've tried this thing around equalisation, and I haven't had a chance to speak to Will, but I have spoken to Sarah C and Mark Rickett and Jagan about this. But you know, we haven't really moved forward with equalising things, whether it's in SNS, whether it's with PLT, whether it's with phlebotomy, blah 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 blah. So there is another way that we could probably string this cat, and I was thinking that really we need to start be a bit more ambitious about what we already do, and whether it means something around sacrificing some of the meds ops audits or something in the SNS that we don't think is relevant to Newham, but we are doing for the sake of doing, etc., and stuff like that, to free up that resource. It's quite clear that finance aren't at the table really to give us that endless pot of cash that we need. It's clear that practices are not asking for more SNSs and things like that, or more things to do, but actually asking free up time to do the things that they think will make a difference. And I think we need to meet in the middle. So I think it'd be good if the working group start to take that conversation forward with the powers that be, really, that if it means sacrificing an audit on a metrazole or something like that to free up more resource to be able to pay for more PLT or support with PLT, then I think that we should start to look to explore that as well. We need to start consuming our own smoke in Newham. We can always ask for money. There will always be an ask for money and more resource, but I think we need to be working much more efficiently in the portfolios that we have and working in a slightly different way. That was just some thoughts and reflections, because there's only so many of us to go around. There's plenty of work to do, so we need to find some efficiency somewhere, and that will be sacrificing some of the things that I don't think we need to do.
So I believe there is a group that is involved in looking at that, and that will be something that we can do within our group. I think it will also need to link in with the work that Nell is doing to standardise what the arrangements are for PLT. But I'll hand over to Sule now and just let her go over what we've got planned for the rest of the year.
Thank you, Leila. Within that context, the first PLT session took place on the 6th of October. Around many of you hopefully were there, and around 80 staff members actually joined that event. Really useful conversations. All the feedback that we have received and the presentations that we actually circulated yesterday. So if you haven't received it, please do let me know, and we can send it to you. Now, in terms of the feedback that we have received and where we are actually moving forward with this, with the context that Leila already provided, we are going to continue with the Thursday afternoons, and we hear our colleagues saying no more than 10 sessions. It is likely that January and August we are not going to be having PLTs because these are early in the month, and January obviously with the new year, and August with the school holidays, etc. We are looking at not having sessions in January and August, but all the other months that there will be sessions arranged. They will be a combination of face-to-face and online webinars. This is what we are hearing our colleagues are telling us. And we are going to be recording all the webinars, and they are all going to be available at Newham Training website. So you are going to all have access to it, and we are going to make sure that the content of each of the sessions is relevant, like mentioned, and also available for covering staff, clinical as well as non-clinical. Maggie, next slide, please. So also there was a conversation in the 6th of October session in terms of there are a number of forums and how some of that can be potentially aligned with the PLT sessions. And at the moment we have the Clinical Pharmacy Forum, Practice Managers Forum, GP and HCA, Community Pharmacy GP Forum, and Personalised Care Forum. So we do need to look at that very carefully, with where there are opportunities. We need to bring that into the PLT discussions and PLT agenda, so that staff members can actually have the protected time and join those forums and discussions and learning opportunities. Next slide, please, Maggie. So for the rest of the year and potentially going into the next year, what we are looking at is 2 borough-wide face-to-face sessions. October was the first one. We are hoping that we are going to have the March session also as a face-to-face session, and start early in terms of planning for that, because venue, etc., parking can be very tricky when we are actually doing face-to-face sessions. But also 3 borough-wide webinars in November, December and February. And moving forward into the next session, next year, as I said, we are looking at potentially 10 PLT sessions in total. Again, 2 of those to be face-to-face. And again, as Leilla mentioned, the PCNs and practices can actually request PCN-based, practice-based PLT sessions through a form, which will be discussed at the transformation group. Next slide, please. Thank you, Maggie. So some of the discussions and topics, there's a whole long list, as I said, we have shared yesterday from the feedback that we have received. So we will be looking at that, but some of that is around CQC, keep coming up, regulatory requirements, PCNs, QI, best innovation, PCNs to actually share their approaches and success stories and things that they are actually doing, something around technology and IT, some of the changes, safeguarding customer care and BLS are the big ones that are coming through from the feedback, not only on the discussions on the 6th of October, but from the surveys, individual conversations that we had with colleagues, etc. And there is a big area around Borough interface in terms of number of different services and how we are actually working with those different services, like the conversation that we just had with Kelley and Children's Services, for example. So there's something around how we can actually bring all of that together in a PLT session. Next slide, please, Maggie. So moving forward, 3rd of November is our next PLT session. That will be online webinar. We are looking at CQC inspections and new requirements. We are establishing a working group, like Wax mentioned, so that will actually, the group itself is going to make sure the content of the sessions are relevant. We are meeting with some of the colleagues. Paul is very much involved from NHC. We are working together on this. On Monday, we will make sure that anybody who actually wants to join and wants to actually contribute into planning sessions for PLTs moving forward, not only for the agendas, but also those wider issues that has been already mentioned. You are all welcome. Yeah, I think that's the best way of actually taking this forward and make the best out of what we have as an offer in Newham. So we are looking at training hub, NHC, PCNs, our ICB colleagues working together to actually move forward. Next slide, please, Maggie. Yeah, I think that's the last one, isn't it? That's it. If there are any questions, any more questions?
No, Sule, I don't think any more questions. There's just a few comments in the chat bar.
Thank you, Arpan. I'll have a look at those.
Okay, good. So
Wax has got a brief one, I think.
Yeah, Arpan, I was just going to say there might, Karen, we might need to, I think as we've spoken before about, is maybe trying to rationalise some of the other sessions we rationalise some of the other sessions we have. I mean, some time from practice council as well, maybe, or do things in a slightly different way, just to support practices, because you know, there's so many things that practices and staff are expected to do and attend, and so many forums which are absolutely useful, and so we need to kind of balance that as well. So
Yeah, thanks, Wax.
I think that's a very fair point, and I think we said, didn't we, Wax, that we'd have a think about how we coordinated the webinar and practice council, so that we can reflect different things, but both have those important issues that GPs need to.
Yeah,
and it makes sense to coordinate with the PLT content so that we're not duplicating as well.
Yeah, and that will help a management team as well.
Good, we've got a few thumbs up there. Okay, so Karen, are you all right to go on to talk about the AG?
Yeah, it's a really quick, Maggie, if you just put the slide up, it was a really quick reminder and encouragement for colleagues to join us next Thursday evening for supper. Hopefully you'd like to come and catch up with colleagues over supper next Thursday. We have a report back for you in terms of what the Federation's been doing over the year. And obviously it's an accountability forum in terms of you talking to board members about what they've delivered and what you might want them to do going forward. But also I think it's an opportunity for a bit of a celebration, and hopefully an opportunity to talk to friends and colleagues over a bit of food. So please do join us. We're at the Granta Hotel this time in Stratford. And colleagues are able to park in the Westfield car park, and we will reimburse you your parking. So please do get along. We'll start proper at 7 o'clock, but there'll be a sort of opportunity for anyone arriving from 6:30, and then as supper at 8 o'clock, so that the meeting formalities will be over within an hour, and then an opportunity to meet with colleagues and have a bit more of an informal conversation. So please do join us. We hopefully have sent you all individual invitations, so do respond if you're able to, but equally if you're not, and if you just last minute get there, we'd love to see you. Thank you, Arpana.
Thanks, Karen. And just following on from that, if anybody hasn't received their invitation that should have, please do let us know as well. Okay, good. Does anybody have anything else that they want to discuss or raise? Sule?
Very quickly, there will be some NEL Primary Care Awards communication coming out for colleagues to be able to nominate staff members, teams, different projects, etc. Please look out for that. We want a lot of people from Newham to be nominated.
Okay, great. Thanks, Sule. Claire?
Oh, hi. Thanks, Aparna. I'm just is asking for help, really. They're trying to review the neuro and stroke rehab service in the community. And the reason I'm involved is it's partly to do with facilitating speedy discharge, because a lot of the beds are blocked when you have a neuro rehab patient. But I think it's broader than that. And certainly I recall when looking after patients who had severe neuro problems, not only stroke, but brain injury, Parkinson's, motor neuron, etc. I was always struggling a little bit sometimes to get the support they needed with rehabilitation. And they're just trying to get feedback from patients and carers. And I was just wondering if the GP community might be able to help. It's a bit of a big ask because they want some questionnaires sent to patients and carers and before the 20th, so it's only 10 days. And they've been struggling. So I was just wondering if there might be a few practices. Obviously, everybody's really busy, but if anybody has any of their admin team that are involved with targets, if they could just do a quick search for their neuro and stroke patients and maybe just send a link that we could send to you via Accurix and just see if those patients could give feedback. Because I mean, I have my opinions. I think the neuro rehab service really needs a bit of a vamp up, but it's more accurate to get feedback from patients and carers. So if people think that's okay, could we send a link round after the meeting, or do people think it's just too much of an ask potentially?
No, I think that's fine. That I'm sure can be shared so that whoever wants to be involved can do that, Claire.
Yeah, that'd be great. Okay, we'll get it sent around after the meeting. Thank you.
Thanks. And then Tammy.
Thanks, Opna. It was another request for a link or to be sent round. Shabnam on our advice and guidance sort of pathway has a survey, and we're really trying to look at the actual impact of advice and guidance on practices. So I have sent an email out to all of the CDs, and I've shared it with Karen, and hopefully that will go out with this meeting. But I'd be really grateful if you could do the survey. It'd be really helpful, and it's according to your practice size. We literally just want the first one that you're doing a day. If you're a smaller practice, it's all explained in the information, but I think it'd be really useful for us to document the workload that's coming with advice and guidance. Thanks.
Thanks. And then Jyoti.
Hi, just a quick reminder to colleagues, if you haven't already booked yourselves onto the LARC introduction training session, which will run on the 20th and the 25th. Organon will be delivering this training. Just a quick introduction to LARC training. So yeah, colleagues, please come along. Thanks.
Okay, good. So thanks everybody for joining today, and we look forward to seeing you all next week at the AGM. And as Karen mentioned, the parking will be reimbursed. There's going to be some lovely food available, including lots of dessert. So please do all come. And we did take your feedback away with regards to the last AGM. So we are looking forward to seeing everybody. Okay, so if that's it, then we'll see you all next week, and we'll see you at the next webinar, which will be next month. Okay, have a good weekend and have a good afternoon, everybody. Okay, bye.
Bye.
Bye, thank you. Bye.
Thank you. Bye. Well done, Arpana. Brought it in bang on time.